Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Ankle.
The ankle procedure is the topic of this lesson, and we've got Jacqueline on the table. You can tell her right leg is the one that's injured because it doesn't have any shoes or socks on. Now we've rolled her pant legs up as well. We have an 11 by 14 cassette, and it is the extremity cassette, lead strips, and an R marker, and we have her protected. Okay. Like other extremities, we're going to be 40 inches tabletop, and we're just going to kind of bypass that on the lesson today because you're experienced students. But I need to get my tube over her ankle, and the 14 by 17 cassette is going to be placed with the ID blocker to the medial aspect of her leg. If it was a left leg, the cassette would be reversed, and the ID blocker will be to the medial aspect of her leg. But her right leg, here, this is our setup. Okay. Divide your cassette into equal thirds. We like to put the L marker on the very first projection, and it's going to be hung anatomical. So this is where I'm going to put it, here, like this, and I'm going to lay it down on the film. Now, ankle injuries, many times the foot, notice how it's kind of in a natural droopy position. We're going to attempt to have the patient flex that foot back. What that does, we're just going to kind of angle your leg off a little bit, Jacqueline, here. If the foot is relaxed position, the os calcis actually comes in underneath the ankle joint. So we flex the foot and see what happens to the os calcis. It goes that way, so the joint space is more opened. Okay? So attempt to flex the foot, do the best job that you can, but patient's pain will probably limit you. And we're going to put the leg down straight on the cassette again. And here's a malleoli. I think you can see that. Another malleoli on this side. Okay. Now, the tibial malleoli is pretty much right at the level of the ankle joint. The fibular malleoli hangs more inferior. It hangs beyond the ankle joint. So my crosshair is actually going to be centered a little bit above this bump. And it's actually going to be right at the bend of the ankle. And I don't know if you can see that, so we'll just kind of do this for a second. Bend your leg or your foot and see the 90 degrees? That's right where the joint space is, right down there, a little bit above that fibular malleolar line. Okay. We're going to do 3 projections. We're going to do a medial oblique, and then in the center section we're going to do an AP with the foot straight up, and then we're going to do a lateral on this projection. Lateral goes off, and the oblique goes off on that side. Okay. The medial obliquity will be approximately 15 degrees. We're going to get here precise in a second because I'm going to look at the intermalleolar line. This is actually called an AP mortise. The mortise joint will be opened up on this one. The mortise joint is the 3 surfaces up through the fibular, across the talus, and down into the tibia. This entire joint space, all the way across the ankle, will be opened if you have a properly positioned medial oblique ankle. I'm going to come over here, and what I mean is properly oblique, approximately 15 degrees. You will know precisely how far to the oblique the leg if you look at the intermalleolar line. Now, Jacqueline needs to rotate her leg in medial just a little more, and I'm putting my fingers right on the very tips of the malleoli, and I'm making sure they're parallel to the plane of the cassette. And in Jacqueline's case, we are about a 15-degree obliquity. Can you see that? Okay. Another patient might only be a 5 degree. And another patient may be a 20 degree. So if you come to the end of your table and you examine the malleoli and you get the intermalleolar line parallel to the surface of the cassette, you will have that AP mortise, and that mortise joint will be a beautiful projection, and hopefully you will be able to get the foot flexed enough to open up the talotibial joint better. So I want my 15-degree oblique. I want the leg coming straight down the cassette, foot flexed, and the central ray coming right down through the fibular malleolar, right at that 90 degrees, exiting to the center of the cassette. There we go. And let's show a little bit of collimation. Let's have a little light over our lead strip, and we're going to collimate in and have about an inch of collimation on both ends of the cassette. If this is equal, you know definitely that you've exited to the center of the cassette, and I'm going to make sure this R marker is within the collimated field. And if you can see the ID blocker here, there is a little bit of shadow over the ID blocker. Okay? What the shadow is over the ID blocker is her first digit here. That is not a part of the ankle joint. So having shadow over the ID blocker is acceptable because, again, it's not the ankle joint. It's this portion of her foot here. Okay? I've divided the cassette into thirds. I've positioned the patient so the intermalleolar line is parallel, most patients being a 15 degree, medial oblique. The ankle joint is to the center of the film. CR is to the center of the film. Equal light, baby light, and an R marker on there. Okay, I can make my exposure and have my patient relax. Notice I have her protected with lead. And then we'll get set back up here. You're going to maintain the same amount of collimation. You don't want the stair stepping. You want everything equal coming across there. And this one is your AP. And it's positioned the same way. The central ray is right at the ankle joint, which is right on the fibular malleolar line. And we want her foot flexed, and we want her toes straight up in the air. Leg coming off straight, foot straight up in the air. Not tipped one side or the other, but the leg coming up very straight. Can you scoot down just a little bit? There you go. Okay. And we can make our exposure. You can have your patient move their leg, and you move your lead strip. Okay. Now, Jacqueline is young and she's mobile. She's sitting up. An elderly patient in a lot of pain, a young patient in a lot of pain, it might be easier for the patient to lie down on the table. I would actually give the option to that patient, ask them how they would be more comfortable, and they'll tell you. When I turn Jacqueline on her side, this is again, the patient might be better off lying down versus sitting up. So we're going to have our patient come onto their injured hip. I'm going to have to readjust this lead strip a little bit. And sometimes it's best to have this leg back, out of the way, and sometimes it's best to have it come up and over like that. So, watch your patient's body language. I'm going to actually ask Jacqueline today how she's more comfortable with it like that, and then she's fairly stable. You'd have to adjust the lead shield to make sure the X-ray photons are protecting that. Reproductive organs, and you may even use a lead shield or a glove a little bit deeper in here. But our ovaries are fine, but this would be an option for you to use too if you needed to. Lateral position, her leg is I'm not going to make her come to the shape of my cassette. I want to go make her comfortable. And that's how she naturally laid. So I'm going to turn the cassette to match her shape. And you can see now that the cassette is parallel to the lower leg here. And I will be adjusting my collimated area to that field as well, fixing my central ray to where it exits to the center of the film. Okay, I'm going to maintain this collimation field here so I don't have the stair-stepping across. I have baby light over the blue strip, and I have a little bit of collimation there. The leg is coming down straight, and the joint space is right through that tibial malleoli. I think you can you see the bump and the central ray coming right there? That's the joint space. It's basically centered right on the tibia. The fibular malleoli goes more inferior than the medial. So I'm pretty much right on the tibial malleolar line. And what I need to do now, I'm going to switch my position. I have positioned the ankle. I want the malleoli superimposed one on top of the other. And I don't know, I'm going to try to make sure you can see what I'm trying to do here. I feel for the malleolar line. I do not pinch the patient. You don't want to hurt this ankle, but I come in with my fingers very gently, and I'm trying to superimpose the two malleolar line. And we're going to elevate her foot just a little bit by moving her knee. I do not handle the ankle, but I came for the knee, raised or lowered that. And her malleoli are superimposed, one right on top of the other. And notice how the foot is slightly up off the cassette. I can stick my fingers in there, and that means I have about a 15-degree obliquity off of the cassette. That has my malleoli superimposed, one right on top of the other. And I'll check my centering now again. Baby light. Central ray coming down the joint space, as evidenced by the tibia malleoli, and a little bit of collimation there. Leg is straight, and that's my third exposure of the ankle. We're going to do a little bit of finessing with this procedure now. We might as well start with the lateral. I want you to make sure that the navicular is included. Okay? Right here. Make sure you get enough of the foot on there to where the navicular is included. It might be necessary for you to clip a little bit of the os calcis if this patient had a bigger leg. Okay? The os calcis is not a part of the ankle joint. So now I'm just making believe, guys, just so I can teach you a principle. This is not good centering, but it's to teach you a principle. See how I have a little bit of the ankle soft tissue over that lead strip? That might be necessary with a bigger ankle. If you use too much space for the other ones, you came with a certain amount of space for the lateral. If you're going to clip the navicular, you might gain some space on this side by sacrificing a little tissue of the os calcis. This would be acceptable. Okay? And when you first start with the oblique, I'm going to move the cassette so you can see too. Many patients, instead of obliquing the foot and the ankle, this is what you want, foot flexed, intermalleolar line parallel. What you might see is the patient actually has inverted the foot. See that? The foot looks like it's obliqued, but it's an inversion and the ankle is not obliqued. So you want to watch out for that foot. Don't accept that. Have the patient relax and bring the foot back into a normal relationship with the leg. Watch out for foot inversion, in other words. Okay? So we're going to recap our positioning. The ID blocker goes to the medial side of the leg. Your internal oblique, so the foot goes off one edge, It's approximately a 15-degree obliquity. It's actually called an AP mortis. Its purpose is to open up the mortis joint. In opening up the mortis joint, the fibula will have a space between the fibula and the talus. Usually the fibula is slightly superimposed over the tibia, but the space between the fibula and the talus is definitely open if you've done a good job with the intermalleolar line parallel, approximately a 15-degree oblique. The AP is done in the center. Make sure the foot is straight up in the air, flexed. The purpose of flexion is to open up the talotibial joint space, keeping the os calcis from obscuring it. Foot straight up in the air, and if you've done a good job with your AP, the fibula will be slightly superimposed over the tibia and the talus. And then a lateral is with the intermalleolar line perpendicular. You will feel and superimpose those borders, and they should be one right on top of the other if you've done a good job according to the criteria that we use for our lateral projection. We're going to kind of review with them, Jacqueline, our protocol here at YVC is a little different than the national protocol. National protocol, what's done in Seattle or what's done in Boise or what's done in Oregon, they may actually have the lateral flat, straight on the cassette. And if the foot is flat, straight on the cassette, the fibula will actually lie posterior to the tibia. Okay? Now, the foot is flat. What's 90 degrees from a flat foot? It's foot straight up in the air. Okay? So nationally, the foot is straight up in the air for an AP, and that's how we do our AP. 90 degrees opposite of that is with that foot flat. But with the foot flat, the fibula will lie posterior on the tibia. That is acceptable according to that protocol. In our area, we want our lateral with the malleoli superimposed. When I showed you the AP mortis, that was a slight degree of obliquity, foot flexed, intermalleolar line was parallel. Okay? And on Jacqueline, it was about a 15 degrees off of vertical. That's with the intermalleolar line parallel. What's 90 degrees opposite to parallel? If it's parallel, 90 degrees becomes perpendicular. 90 degrees becomes perpendicular. Rather than parallel, it becomes perpendicular. And our lateral, we want the malleoli superimposed. We want the intermalleolar line perpendicular, in other words. So our lateral is with the foot slightly up off the cassette, approximately 15 degrees. It's 90 degrees opposite our AP mortis. Okay? If the patient's intermalleolar line is parallel with only 5 degrees, then the lateral would be 5 degrees off of the plane of the film. If our patient was 20 degrees for the AP mortis, for the lateral, it would be 20 degrees off of the plane of the cassette. Think of the relationship of parallel versus perpendicular. Because sometimes when you feel for the lateral, trying to feel for that malleolar line is difficult. You know, to feel the edges and to balance the fibula and tibia, one right on top of the other, can be very, very difficult. But if you remember what your degree of obliquity was with the AP mortis, if it's 15 degrees, all you have to do on your lateral, if your criteria is to have the intermalleolar line perpendicular, is to make the foot 15 degrees off the plane of the film. Was that explanation clear to you, Jacqueline? Yeah. Okay. We may have to discuss this more at a different lesson. The AP positioning criteria, let me review with you. I'll do the oblique first because that's what we shot first. The fibula will be free. The joint space between the talus and the fibula will be opened. Most of the time, the fibula will be slightly superimposed over the tibia. That's a good projection of the AP mortise. The entire mortise joint will be open, approximately 15 degrees medial oblique. AP, if the foot is straight up in the air, the fibula will be slightly superimposed over the tibia and the talus. And lateral, in our region, our criteria is to have the malleoli superimposed, the distal tib and fib, in other words, directly right on top of one another. And that will do it for today.